Hello, everyone. My name is Nicole Fram, and I practice at Advanced Vision Care in Los Angeles, California. And my subspecialty is cataract, cataract refractive, complex cataract surgery, and cornea surgery. And so, what I wanted to talk about today is how do we take a complex case and make it feel routine, meaning that you have all the skill set, you pulled everything ahead of time, and you really understand how to make that really complicated case be systematic and every move is deliberate so that you're not panicking. So let's get through some of our material here. There's are my financial disclosures. There are certain cases that make your blood pressure rise. That's not me, but it has been me after a very challenging case. One is posterior capsular rupture, anterior capsular tear, loose zonules, which is what we're going to talk about today, white cataract, or a really dense brunescent cataract. And the loose zonule can be a really challenging thing. It's probably the most common thing that we see in our patients with pseudoexfoliation, patients that have had a trauma or they've had a pars plana vitrectomy or anything like uveitis or things that can cause a breakdown of the blood aqueous barrier can affect the zonule, and then the zonule becomes weak during the case. And if you don't watch for the signs, this was a case of a traumatic zonulopathy caused by a surgeon, me grabbing the bag because we were not on polish. That can be really upsetting. So what do you do in this scenario? Well, you refill the bag. Hopefully a CTR will be enough, but sometimes you have to learn how to do a suturing technique. But if you actually take on these cases before you get in an OR and have a complication and then learn how to do it, if you deliberately take on these cases, then you have that muscle memory to know what to do when something actually happens. So the preoperative signs of zonulopathy when you're seeing the patient at the slit lamp can be phacodenesis. You want to see them before they're dilated because it's sometimes a little bit more obvious. In trauma, you can have asymmetry of the anterior chamber. So some parts of the chamber seem deep and some parts seem shallow because the lens is tilted. You can have, gross lens subluxation that makes it really obvious. Pseudoexfoliation, seeing different pseudoexfoliative material at the iris margin or they don't dilate well. These are your clues that something's going on. Angle recession from trauma, or if you see a big iris defect from trauma, underneath that, there could be some zonulopathy there, and then congenital for iris coloboma. So looking at those preoperative signs and then saying, you know what, I'm going to schedule this case for an hour and not for a half hour as your block time, will really help me get the stress off of me. And I'm going to have a block on standby in case the case starts to go a little bit crazy so that the patient can be comfortable. All those things will help you be successful in making a complex case routine. So this was a patient that was actually had a complication in their first eye. They have pseudoexfoliation. And my mom referred this patient to me. And she said, oh, you had a problem? Well, go to my daughter and she'll fix your other eye. No pressure. So they come in and he has a loose lens and pseudoexfoliative changes. And I'm supposed to be the hero because the first doctor screwed up the first eye. So the pupil doesn't dilate well, so I couldn't cheat with a femtosecond laser. So let's see how this goes. Now you can use a Malyugin ring or you can use iris hooks. I prefer iris hooks when I think I'm going to use capsule retractors, but you can do it either way. I stain with trypan blue. And then, you want to paint the capsule so that you can actually get a good stain going. And you could tell when I initiated the capsulotomy that you saw this kind of elephant skin or like the whole lens started moving. So here we put viscoelastic under the anterior capsule and use these MST chain modified capsule retractors. And those serve as your artificial zonules during the case. And then you can do your hydrodissection normally. You can do whatever chop technique you like. And often I'll come out of the eye, like I'll try a bimanual approach, but if it doesn't want to move because the zonules are so weak, I'll come out with viscoelastic and then turn it to where I want to be, where I'm safe. You want to have your fluidics kind of slowed down in these cases because right when you get to the last few pieces, your capsule bag, because it doesn't have the equatorial zonules that are, and the anterior zonules that are really taut, it can jump into your phaco tip. And so here I'm filling with Viscoat so that I keep the capsule bag back before I go and take that piece. So I like a bimanual approach when I get the Cortex, and I'll actually, Alan Crandall and Bob Sione taught me to Visco dissect the Cortex off the anterior capsule before I try and get everything. And then when you go to put a CTR in, you want to really fill that capsule bag, not the anterior chamber, the capsule bag. And we'll put this in a bimanual approach so that you put the least amount of stress onto the zonule. And if you know there's one area where there's a lot of zonulopathy, start the CTR in that direction so you can recruit the good zonules. And then you can come back and get other cortical material, but I like to wait as long as I can before I put a CTR in so that the Cortex doesn't get caught. I'm putting in a nice platform lens that's, kind of really friendly to go in. So a high index of refraction lens is fine. So here, I think the case is over. I'm like, I did it. I got it in the bag. My mom will be proud. And I start seeing there's a ton of little epinuclear material that's gone behind the lens. So I know I disrupted the anterior hyaloid membrane. I also, was testing it out, and the lens is like, hey, like wiggling. I'm like, I can't leave this guy like that. Like if I leave it like this, now he's going to come back, and then the lens is going to fall, and then my mom's going to get mad at me. And so I'm thinking about all these things, right? So what I decided to do was to put in Ahmed segments. And so these segments are designed to kind of reinforce the equatorial zonules. And so I made an incision with a 23 gauge equivalent MVR blade, and we're going 2 millimeters posterior to the limbus, and I'm coming out under the iris but over the capsule. So that's where the sutures are coming out. And these rings, so there's a whole part of the ring that's in the equator, and then this loop, and the loop sits on top of the capsule. And so you can see how we're kind of titrating how we can stabilize this lens. Now this is Gore-Tex off-label. Everything I'm doing is off-label. And I tie in a 2-1-1 fashion, or you can do a slip knot. And as we do this, you want to make sure that you don't pull too hard to one side, so you're constantly titrated. Now you can use 7-O-proline in a flange technique, but when you do that, sometimes it tends to tiddlywink a little bit. So I still prefer the Gore-Tex, but I'm working out the 7-O flange technique as well. And when you tie Gore-Tex, you really want to make sure that you tie to one side, because you have to bury the knot and the ends. So it's really important. The nice part about Gore-Tex is if you tie too tight, you can untie it with 2.12s. So here we're just titrating. I'm using the circularity and the centration of the anterior capsule to see how much I want to titrate the Ahmed segments. And now you can see when we go in with the IA, it's just this nice, stable chamber. You don't see the whole thing wiggling around. And I know that at the end of this case, there's going to be a really great result. So here we took a complex cataract and just made it routine because we were ready for all these things when it happened. I always put a little bit of washed Kenalog or non-preserved triamcinolone so that I can make sure that there's no vitreous prolapse, because you saw how loose the lens was, that can happen. And so the case finishes up nicely, and he did great. So here's another case, which is a patient that came to me with a blown pupil from a tennis ball injury. Nicest woman in the world. She always tells me she loves me. I was like, I haven't fixed you yet. She keeps saying she loves me. It's like crazy. But now she does. I wanted to use the femtosecond laser because, why wouldn't I cheat? I'm a cheater. And what the femtosecond laser allows you to do is to center on the center of the lens capsule if your pupil is dilated big enough. And so you'll have this really nice centration. It allows you to make the proper size, because we tend to make smaller capsulotomies or capsulorhexis when we have loose zonules, because it just kind of like pulls you inside. So I decided to stage the procedure and just do the cataract portion first, and then 6 weeks later come back for the pupillary cerclage. And you'll see why, because pupillary cerclage is the hardest thing to do in the world. And I'm not Brandon Ayers, and I'm not Aikma Ahmed. I'm Nicole Fram. And sometimes I just don't want to hit the capsule, like when you do this great surgery and then you can't get through it because you rip the capsule, it's really sad with the needle from the pupillary cerclage. So let's get into this case. So first I put some viscoelastic to block where the zonulopathy was. And I wanted to block it because I don't want this trypan blue to go posteriorly. A better thing to have done would be to put cohesive in and then paint the capsule where I want it on the anterior capsule. So now we're removing the capsulotomy, and I put viscoelastic under the anterior capsule so that I can make room for these same Chang capsule retractors here. And now I can do my normal hydrodissection, and I want to blot every time. And then I do a little more viscodissection, and I try not to spin. You can kind of feel if the lens is loose. And in these kind of cases, do your best technique, whether you want to be a horizontal chopper, stop and chopper, a vertical chopper. I don't like to put a lot of posterior energy down, but I'm able to do this bimanual turn. And it's best to try to, pick things up. And a piece won't come right away. Just go to another piece. And then eventually everything will come up. So here we're just removing it. You can see how easy, why wouldn't you use femtosecond laser to make everything so much easier? And when I'm thinking, I'm like, okay, what am I going to do? Am I going to do OMID segments on this patient, a CTR with OMID segments? Well, if it's greater than 3 clock hours, then you definitely want to use a sutured segment. Or you can use a sutured ring. So it's a capsule tension ring, either a Sioni ring or the ring jet, where there's actually a modified ring that you can suture in one area. So we're taking the last piece out. We're going to fill with viscoat so that we push that posterior capsule back, and then we go ahead and get our last piece out, and hopefully the posterior capsule will not jump into our phaco tip. We lowered our settings, we lowered the vacuum in a controlled fashion, and then we fill every time we come up. So you go to position 0, and then through a paracentesis you fill on the way out so that you never destabilize the chamber, and hopefully no vitreous prolapse happens. So here, same bimanual technique, but this is with the polymer, bimanual polymer tip, and it's really nice and friendly. And we then refill again, filling the capsule bag and not the anterior chamber, and I like to polish. So why am I polishing? That's the Singer sweep, because we don't want capsule phimosis, especially when we have rings and things in the eye, because that will stress the zonules and cause the whole complex to move over time. So this is a preloaded ring jet CTR that I then put Gore-Tex suture on so that I can kind of bring it all the way around the equator, into the equator of the bag, and then I'll just suture that portion. Here we're taking out our capsule retractors, and this is actually just a 23 gauge equivalent blade, paracentesis blade, that we can use, and I'm 2 millimeters posterior to the limbus, and with Gore-Tex now I'm definitely putting it into a groove, especially when you don't have a lot of tenons, because you don't want the Gore-Tex to extrude over time. So here we're going to do just kind of a handshake technique. I'm not using any needles, so it's a needleless recovery technique with some microsurgical instruments. And we retrieve that, so we were under the iris but over the capsule. Same thing on the other side. And you can see it's a little awkward. I'm just kind of like hand over hand. So I think I came out and I went through another paracentesis, and that made it a lot easier. So your ergonomics of where your positioning is really important during these cases. So we then put the lens in. So don't tie down the OMID segment or the sutured CTR area before you put the lens in, because sometimes you can rip the capsule because it's so taut on there when you're putting the lens in, and then it makes you really sad inside. Ask me how I know. So now we're doing it again, tying in a 2-1-1 fashion, and what we'll do is just keep titrating the tension that we want. And remember, we're not trying to tie it too tight. We just want it to be stable over time. If I didn't suture this area, then the whole complex could move over time, because it was really about, at least 5 clock hours of zonulopathy. And you'll see I bury the knot and make sure I'm happy with the position before I cut. That looks great. And then I can use some to seal glue, or I can close the sclerotomy over where the knot is. And then the case finishes up great. Obviously, checking to make sure there's no vitreous prolapse is really important. So she did great. After that, this is what she looked like. So we opened the posterior capsule, and this is what her her pupil looks like, so I have to put it together. So pupillary cerclage is the hardest thing we do. And I'm going to show you that this is a really good pupillary cerclage because it wasn't perfect. And I'm going to show you how to make it perfect, even if it's not perfect from the start. So I make 4 paracentesis. I put some myocol or myostat in. And then I kind of want to take these 23 gauge serrated forceps and kind of grab around to see how much tissue I have to work with and how fibrotic it is. And so we're really just kind of weaving the iris over the needle. So this is a CIF4 10-0 polypropylene needle made by Ethicon. And we're just weaving this. And you want to, I mean, when I watched Ike's video, he was like, get 10 throws on top of that needle. I got 7, so I was really happy about that. But you just need to keep one hand still, and you really don't want to pull too far centrally because you can cause an iridodialysis. So you always want to be paying attention to what's happening out in the periphery with your other hand, because you can really just start concentrating. And then when you come out, you want to dock it into a 27 gauge needle. This needle is tapered, and what that means is if you try and just push it out through the cornea, it's going to leak. If you use the CIF4 that has a spatulated needle, you can kind of come out at the limbus and it's a little bit better. So then you take the other side and you do the same thing and you just start weaving over it. And it's really something that, like, sometimes, you're using your left hand and your right hand. And sometimes in my mind, I'll sit there and say, I only have a left hand, just kind of like make me, be able to like put all my brain energy into making that and have the same dexterity as my right hand. But it definitely takes some practice. And so, I'm feeling pretty good. I'm kind of annoyed because there's one section up top where I could have done like a couple more throws. So I'm already thinking to myself, how am I going to make this better after I complete the whole cerclage? So we pull that through, bring it back into the eye. So that side I think was really good. And instead of using my left hand for this pass, I was able to come out through a paracentesis and then use my right hand again, so that I have a little bit more control to hold the needle. Because the needle, you have to have a really firm grip on the needle. If you're not choked up enough and you don't have a heavy needle holder to hold it, it starts tiddlywinking. It has like a mind of its own. So practice just holding the needle and making sure it stays where it's going to stay. So here we're coming up again, and then we go down the other side and we make a few weaves there. And here we're using a micro grasper, which we really like for this procedure. Now, now comes the stressful part. I mean, that's not stressful enough, but the stressful part here is that, first of all, I'm like, why didn't I just put in an artificial iris? But I needed to have a video to show you. But I'm thinking, okay, I cannot break this thing as I'm tying it. And then how do I get it to a perfect 3.4 millimeters? Well, we all know the mechanical suture technique where you do a pass. It doesn't matter where you go in and where you come out. You make a paracentesis perpendicular and you retrieve the suture out and tie. This is, and then we have the Siepser technique where you have to go through a paracentesis, come out the other side, and then it's a Siepser sliding knot technique. This is a Mick-Ahmed, so it's a combination between a mechanical and a Ahmed modification, and that's where you start tying and then you push one free end into the eye, and with a micro forceps you can pull and have complete control. So here we're happy because we're about at 3.5, but we have these 2 gap areas. And so I'm going to show you that you can just throw some either 4-throw pupilloplasty technique, or you can do a Siepser sliding knot to kind of do that. But you see how I'm in the eye and I'm able to really titrate the ability to allow this to have the right diameter. And sometimes, if you pull too tight, it's game over, right? Now you got a pinhole pupilloplasty. But I was really happy with the way this looked, but you saw those little skip areas. So my lesson is that when I go in, I'm going to really try and be tight on those first 2 throws. You always learn something every time you go back and watch a video. So here I'm just trying to do, this is just going to be a 4-throw pupilloplasty technique where it's very similar to the Siepser, but you're not going in and out of the eye. It's just one pass. You retrieve the suture through, and then you just wrap the free end around the loop 4 times, and then it goes in. These are actually Epsilon modified bond hooks. So they're really great because they don't get caught up on anything and they're smooth. And so we retrieve the suture that way. And I'm just doing that 4th row where I'm taking the end of the suture and wrapping it around the loop. And then you're going to see that we just propagate that right into the eye in just a moment. So one more throw for good luck. Is that 4 throws? Is that 4 throws or 5 throws? It's the 5 throw pupilloplasty today. And then we're going to hold and then watch it propagate all the way into the eye. And it looks really nice. And then should I do one more? I did one more. And then it finished up really nicely. So this is what she looked like. So preoperatively, she's been living for the past 20 years with everybody saying to her, are you having a stroke? Is there something wrong with your eye? She was 20/70 best corrected with a traumatic cataract. And then post-operatively, you can see that now she looks way more symmetrical. It's not perfect, but it's close to perfect. And she's really happy with her vision, 20/20 best corrected. So that's what I have for you in terms of the videos to go over just, where we, got all of these instruments. You can use the MST capsule retractors, but make sure they're the Chang modified. There's a Yaguchi Kazawa that really go into the equator more, but it's hard to find and hard to order. These are the capsule support devices, and there's some great new inserters that are coming out that can help you put the capsule retractor in the eye, because there's a lot of back orders or supply chain issues. So you really know how to have an inserter that you can load yourself. But I think the take-home points is that everyone will encounter a complication. And I think the best way to make a complex case routine is to try and take these cases on. Make sure you block the patient, have the right anesthesia, have the right plan A, B, and C. Pull everything. The nurse, it may not be experienced that's in your room. Pull everything for them. Have everything in one bucket is plan A. The next bucket is plan B. The next bucket is plan C. And be ready for it. And then when something happens in the middle of the surgery, you don't lose all feeling in your body and start panicking, right? You know what to do because you've already been there because you planned it. And then stop and refer. Let's say something happens and you're not comfortable. I wasn't comfortable doing the pupillary cerclage at the same time after doing all that work with the capsule. Come back in 6 weeks and you can, do your pupillary cerclage and iris work later. So thank you so much to BVI for putting on this incredible series. And it's been an absolute pleasure sharing these cases with you.